regarding obstetrics and gynecology health, treatment and recovery issues. Lined up, we have 4 speakers who are up to their task. And before we start, I'll request that someone prays with us. If you can kindly pray with us. Someone confirmed that you can hear me, and therefore I believe even as I speak now, you are able to hear me. Please, somebody pray with us. Thank you very much. Are you still able to hear me? Kindly confirm so that we start on the same footing. You can put it in the chat. Oh, thank you very much. I can see Dole, and I think that means you can hear me. Allow me, for the purpose of saving time, that I pray with us. Let's pray. Father, we thank you. We bless you. We honor you. Thank you for this afternoon, even for causing us to meet yet again as we had planned from last week. I thank you for those who are logged in, the 280. And I believe and trust that you're going to quicken others to join. Thank you for the speakers. We pray, about Father, that you're going to enable us to be successful. Even as we tag others to join us, we believe we shall increase. And above all, that the knowledge we are going to receive today is going to be translated to the care of our patients. It is going to change and turn our healthcare institutions around. And therefore, we bless you, we honor you in Jesus Christ's name. Amen. Thank you very much, even for lobbying the early bird. Indeed, the early bird catches the worm. And I believe today's worm is going to be one of the best. Lined up, we have 4 speakers, and I'm happy to introduce the first speaker. The first speaker is Tessa. Tessa, are you able to test your mic?
Thank you, Dr. Muse. Am I audible?
Tessa, can you kindly test your mic before I introduce you?
Yes, good afternoon. Am I audible?
Are we able to hear Tessa, all of us? Tessa, speak again, please.
Yep. Yes, we can hear Tessa. Maybe
Wow.
from your side.
Thank you, Mr. Mwenda. I can hear you clearly. And therefore, I'm privileged to introduce Tessa to us. Tessa is a principal nursing officer. Her 2 names are Tessa Shitandi. She's a principal nursing officer who is working in Kenyatta National Hospital, Obs-Gynae. And she has a master's. She holds a master's of science in nursing with a specialty in midwifery. And she's a PPH champion. She's also a researcher and contributor to Women Health Initiative. And we are privileged to have Tessa speak to us in the next minutes. Tessa, kindly, if you can take the floor. Thank you.
Okay, thank you so much, Dr. Muse, for that introduction. Good afternoon, everyone. And thank you so much for joining in this webinar. Thank you also for the opportunity that you have given me to disseminate results that I did on a study I did some time back. So as you've heard, my name is Tessa. Just to add, I'm a very passionate midwife working in Obs and Gyn. So I'd like to ask Mwenda to share my slides.
Mr. Mwenda, if you can share the slides, please, for Tessa Shitandi.
Okay, thank you. Thank you, Mwenda. I hope it's visible to everyone. So this is a study I did alongside Professor Madeka, who's affiliated to University of Nairobi, and Dr. Joyce Chebet, who's affiliated to Aga Khan University. So my topic of study was health education messages shared with postnatal women in the postnatal wards. So I'm sure maybe you'd want to know why the interest in this. Why I did this was I noticed there's a gap on what information women are receiving post-discharge. So I sought out to know what women know, what they want to know more. And I also wanted to know, there's a worrying trend of babies coming back with acute kidney injuries. And from our audits, these women, they say they don't know how, they didn't know that no urine output in 24 hours can cause acute kidney injuries. So we had a rise of babies with acute kidney injuries, and also mothers were coming with sepsis. So I sought to find out more. Next slide. So this is just my presentation outline. Next slide. So a bit on the background. Right now in Kenya, the maternal mortality rate is actually 362 per 100,000 live births. And this was in 2021. And so we need to reduce this MMR rate, and all measures we need to put across, like giving health education messages can help reduce these maternal and neonatal mortality rate. So another thing, targeted postnatal care. According to the national guidelines on quality obstetrics and perinatal care, it spells out that all women should receive targeted postnatal care. When you look at these guidelines, it actually spells out what the women are supposed to do, what the women are supposed to be health educated on, the timing and the content that us as health workers should give to these women. So another thing, the education and support women get during postnatal period has a significant impact on the practices the mothers pursue post-discharge. And this is according to ASCO 2019. So another thing, sufficient dissemination of information to mothers improves health outcomes for both mother and baby. Next slide. So this was my problem statement. This is a study I forgot to mention. I did it in 2022. So for this problem statement, globally, 57% of women die, and babies, they die around the immediate period after childbirth, posing a great danger to both the woman and her newborn baby. So you realize if we give these women health education at this period, we'll be able to reduce the neonatal and maternal mortality rates. Another issue is that there's marked increase in institution deliveries. And because of the high numbers, we usually discharge women early. And this early discharge makes us not to give enough information to these women. Then again, most of the postnatal care occurs at home. We are only having these mothers for 3 days, but for the rest of the 6 weeks, these mothers are at home and we need to empower them. Another thing also, in KNH between 2018 and 2023, the mortality rate among the postnatal mothers was 28.2%. That is actually high. And for babies, it was 33%. A study on essential newborn care among 380 postnatal women in Machakos noted that there are gaps which exist in newborn education and postnatal education. So I thought it's better to also do this at Kenyatta National Hospital just to see where we are. The operational guidelines and standards of health information state that a quality health education should be simple, it should be clear, and it should be limited to a number of concepts and should reflect the learning style of the audience. Next slide. So my main objective for this study was to examine the extent of health education and health promotional messages delivered by healthcare workers to postnatal women in the postnatal wards. And as I said, this was a period between January 2022 and September 2022. Next slide. The methodology I used, I did a descriptive cross-sectional study. The study area was the 3 postnatal wards in Kenyatta. Of course, there were others in the private wing, but I focused on the general wards, the 3 postnatal wards. So my study population were the mothers who had already delivered and they were actually in the process of discharge. My sample size was 118 as per Fisher's formula. I did a simple random sampling. It was an interview administered questionnaire, and ethical consideration was sought from KNH ARC, NACOSTI, Kenyatta, and of course, consent from the postnatal women. Next slide. So these were my results. Demographically, most of the respondents, around 52% were aged between 18 to 29. You can see this bracket. These are very young women. The mode of birth, most had normal delivery at 79%. So 72.4% of the respondents received the health messages on postnatal care immediately after birth. And these health messages, they agree that it was given in groups and in a language that they understood. And our women, they prefer demonstration as the best form of communication as opposed to the 30% booklets. Next slide. So I tested their knowledge on postnatal care. So these are some of the topics that we are supposed to teach them, from emptying the bladder to neonatal danger signs, up to cord care. I believe you can see that graph. So the blue color denotes what these women have been taught on. You can see that many women agree that they have been taught on exclusive breastfeeding, how to birth their babies, personal hygiene. But then there are some things we did not teach them about. So they were not aware on when to resume sexual activity. They were not aware, okay, the danger signs, what they were aware of was just the fever and, not breastfeeding well, but other danger signs they did not know. They also did not know about cord care, and something about cord care, which actually is interesting to note, and I was surprised. I asked one of the mothers if she was taught about cord care. She told me yes. And I asked her, so how are you taking care of the cord? So she told me, I just pour breast milk on the stump. I don't think at this time mothers should be saying that, because others don't know about chlorhexidine. They don't know if to use surgical spirit. Yes, they are not aware of that. Next slide. So I also sought out just to find out these messages, who taught them. So as you can see, the nurses take it. They gave them health education about cord care, immunizations, neonatal danger signs, perineal care. But there were other cadres I've written others, but they involve the nutritionist, the physiotherapist. Then they focused on breastfeeding. The nutritionist focused on breastfeeding, the physiotherapist on postnatal exercises. The family planning and mother danger signs were mostly given by the doctors. And I think nurses, we should be able to give all these health talks and not just the other cadres. Next slide. So in conclusion, yes, the mothers are getting this information. They receive information after birth, but as you can see, there's more focus on breastfeeding and less focus on other aspects. The mothers also agreed that they like being taught by use of demonstration, lectures, charts, and booklets, and they prefer being taught in groups rather than individually. So also most women, they understood the language that they were taught on, but we had women from the minority groups, maybe the Maasais. I also encountered physically challenged women. Some are deaf and dumb, and they were not able to understand. Okay, as much as even the nutritionist was talking to them, they only understand sign language, so they did not get anything. Next slide. So as I said, this is a study I did in 2022, and actually most recommendations that I had put across have been implemented. And so at this time, I want to thank the Senior Principal Nursing Officer of Obs and Gyn Unit. She has really, through her leadership and in collaboration with the various unit heads, has made sure that most of these recommendations are implemented. So like right now, health education is being initiated in our postnatal wards, all the 3 postnatal wards. Despite the staff shortages, she made sure that as a nurse is assigned every day, especially the days that we are on call and post-call, so that we are able to capture all these women before they go home. And they are given health education on all the topics that they're supposed to know. Even the resumption of sexual activity, people are not shy to give facts about that. So there's actually been a register in place, and we are capturing the names of the clients and their contacts. And I'm sure in future we will have quality audits just to follow up on these mothers and get to know how they are faring on. And hopefully we'll get a decrease in the number of neonates coming with AKI and even the mothers coming with sepsis. So another recommendation, which I hope and pray that will be put in place, is to train nurses on sign language, especially to address any communication barriers, sign language and interpreters in all units, so that these mothers do not miss any information. Another recommendation is I'd recommend that further research is done to other hospitals. Maybe we see where we are at, then we can compare ourselves as an institution. Next slide. So these are the shortcomings of my study. Of course, these results are not generalized to other facilities. They could be, I don't know, they could be doing better than us, I don't know, or yes, but it's good that it is done to other facilities. Then, of course, language barriers, communication challenges with the deaf, that is what I encountered. And then other shortcoming is that most women still deliver at home and miss the messages, only to present in the facility on the 6th week of for immunization. Next slide. Okay, so just to sum up, I believe the first contact a patient has with the healthcare provider greatly influences health outcomes. So when mothers come for delivery, they expect to be given all services holistically, and this is their basic right, as it is in the Constitution. So let's empower our women with this information just before they leave the hospitals. As I carried out this study, I noticed our women are so hungry for information. They are so hungry. And right now, there are NGOs, there are individuals who have noted this hunger, and they have created online platforms which mothers subscribe, or there are even content creators who have their pages on YouTube. So mothers get to subscribe and they're given the information they need. But let's think about that mother who doesn't have any airtime, any data bundles, even a smartphone. Where does she go to? She knows when she goes to the hospital, in the public facility, she'll get all the information, but yeah, she's not able to get to. So let's empower women. So yeah, that was that. For more information on this study, you can find this article published in the African Journal of Midwifery and Women's Health, or you can also find it in the UON repository. Thank you so much.
Thank you very much, Shitandi. I think that was clear. Simple research with great recommendations. Simple recommendations that when implemented, they can bring a lot of quality improvement, even as we look at reproductive health in our nursing endeavors and in the care of the patients that are in reproductive health age. Having said that, we have our next speaker, Lynette Aoko. If you're able to test your mic as I introduce you.
Hello, can you hear me?
Wow, thank you. We can hear you. So Lynette Aoko is our next speaker. She is a specialist in postpartum family planning. She holds a degree in nursing and master's degree in public health, and she has interest in sexual and reproductive health. Throughout her academic and professional journey, she's been committed to advancing the health and well-being of individuals and communities, particularly in the domain of sexual and reproductive health. Her background has provided her with a unique perspective, which helps to bridge clinical expertise with public health strategies to address complex health issues. So today she has the privilege to speak to us, and therefore, as we appreciate you, Lynette Aoko, you may take the floor and kindly take me 10 minutes. Thank you so much.
Thank you so much for that warm introduction. Mwenda, kindly share the slides.
Mr. Mwenda, if you can kindly share the slides for Aoko. Thank you so much.
So my research was based on the factors associated with uptake of postpartum family planning methods among postpartum women in Muhoroni Sub-County, Kisumu County, and my name is Lynette Aoko. On to the introduction. We find that postpartum family planning is the initiation of family planning services within the first 12 months following childbirth to prevent closely spaced and unintended pregnancies. Also, worldwide, there are 265 million unwanted pregnancies, 110 million unnecessary abortions, 590,000 avoidable maternal deaths, and 8 million preventable infant deaths. Sub-Saharan Africa has one of the highest fertility rates in the world, which is promoted by the low utilization of modern contraceptive methods. In Kisumu County, the contraceptive uptake level is 62.4%, and also 29.8% of the births occur between 7 to 35 months. Pregnancies within the first, onto the statement of the problem, we find that pregnancies within the first 12 months after a birth may lead to chronic undernourishment for the baby, stunted growth, and infant mortality. Kisumu County is characterized with a high fertility rate, low per capita income, and high child mortality rate. The justification of the study was adequate space intervals between pregnancies contribute to the fertility rate of women and also the health outcomes of the mother and child. The purpose of postpartum family planning is to help women decide on the contraceptive they want to use, initiate that contraceptive, and continue contraceptive use for 2 years or longer. This helps prevent adverse maternal and perinatal outcomes that postpartum family planning use is of importance. My objectives, the broad one was to determine the factors associated with uptake of postpartum family planning methods. The specific ones were, the first one was to determine the social demographic and social economic characteristics. The second was to determine the proportion of postpartum women using the postpartum family planning methods. The third was to determine the contraceptive methods used. And the fourth was to determine the barriers to uptake of the postpartum family planning methods. The study was conducted at Muhoroni Sub-County. A descriptive cross-sectional study was used. The study was a mixed method which involved both quantitative and qualitative method. The sampling procedure was a two-staged cluster and simple random sampling. My inclusion criteria involved postpartum women who are willing to participate, and the duration of the postpartum period was between 4 to 24 weeks. The exclusion criteria were those who are less than 4 weeks or more than 24 months postpartum, and also those who had no need of family planning. 210 participants were interviewed and 40 patients for focus group discussion was done. Data was analyzed using the SPSS, descriptive and chi-square tests. Qualitative data was analyzed using Atlas, and ethical clearance was sought from Baraton, Kisumu County Research Department, and the participants also voluntarily participated. The results, as we see, the use of family planning, we can see married women used family planning more than the single ones. Onto the education levels, those who had secondary educations were higher. And also the age group of the people using family planning, which was higher, was between the age of 25 to 29 years. Next slide, please. Onto the employment status, we find that the self-employed women had a higher rate of using family planning methods, and on religion, 65% of the Protestants preferred using family planning methods. The period of waiting during the use of family planning method was 1 to 2 years. Those who wanted to stay without giving birth to the next child delayed between 1 to 2 years. Next slide, please. That's my univariate analysis. We can see where it's bold. It's where we found that there was an issue. Then we proceed to the multivariate analysis. Then the bold ones, such as the age of the mother, secondary, and the housewife characteristics were seen. Then we go to the next slide, please. On to the discussion on the social demographic and socioeconomic characteristics. We find that the significant predators were age, occupation, and employment status. Women age, level education, parity, religion, and duration of marriage played an integral role in uptake and utilization of postpartum contraception. Increase in the education level raised the chances of using contraception. Post-primary education was associated with increased odds of modern contraceptive use. Low education level was associated with the lack of awareness and accessibility of family planning services. On to the proportion of postpartum women using postpartum family planning, we found that the prevalence was 46.8%. It was lower than the study conducted in other areas. The discrepancies could be due to the socioeconomic differences, cultural variations, service accessibility, reproductive characteristics. We find that both unmet and met needs were categorized as such based on whether the need is for spacing or limiting births. On the methods used by family planning, when we zoom in on the chart, we find that the methods of family planning which was the most known, was the injection, but methods of family planning which was most used was the implant. On to the next slide, please. Still on the contraceptive methods used, we find that most common known method was the oral pill. Of family services, because the methods were easily affordable, readily accessible, and also do not necessarily require a skilled provider. That was on the oral pills. And healthcare workers were putting in more effort in talking about the different methods, though some participants felt that the healthcare workers only talked about the methods they had in the facility. On the barriers to uptake of postpartum family planning, the barriers found were breastfeeding, distance to health facility, health worker factors, male involvement, and fear of side effects, and perception of other people concerning family planning methods. Some of the women say that most of those healthcare workers ask us to choose method of family planning, knowing well that the only thing available is the pills, and I don't want that. Another lady said, other people usually feel that these family planning methods are not safe, and some don't even prevent pregnancies. Still on the barriers, the health providers and the media were the frequent source of information. Factors that influence the partner's attitude towards contraception would also affect the woman's use of postpartum contraceptive, either negatively or positively. Contraceptives brought health problems like severe abdominal and leg pain, heavy periods, and also late periods. The KDHS report showed that health-related concern leads to non-use or contraceptive discontinuation. Next slide, please. On to my conclusion, we find that the prevalence of postpartum family planning use was low at 46.8%. The significant predators were age, occupation, and employment status. 47% of married women were not using any method of family planning. 51.7% wanted to delay childbearing for more than 2 years, but they were not on any long-acting method of family planning. Most of the postpartum women were using contraceptive methods different from their methods of choice. This could be due to the unavailability, lack of counseling on the available methods, or influence from other people or sources. My recommendations were, the first one was the community should be engaged frequently on the benefits of postpartum family planning through the use of media and barazas, especially now that we are in the online world. Content creators can also help us more into telling people about the postpartum family planning methods. The government should also offer adequate counseling on the importance of postpartum contraceptive methods. Then I managed to publish the paper. It's in the East Africa Medical Journal. You can check it. Also, it's also in the JQuat repository. Thank you so much for listening. I really appreciate this chance to be able to disseminate my data.
Thank you so much, Lynette. That was great. Congratulations on your publication together with Shitandi. Beyond just the oral dissemination, we also need to publish so that we can reach out to the bigger community. Other than what the community can do and what the government can do, I expected you to have put a smaller recommendation that where even the facility and the individuals in the facility could work together with the people so that they can address the issues found out. Nevertheless, it's not time for question. We shall engage in the plenary. And therefore, ladies and gentlemen, continue to put your questions in the chat. I've already picked 2 items and I'll continue to pick more as we proceed. Our next speaker is Mary Marigi. Mary Marigi, if you can test your mic before I introduce you. Is Mary Marigi? Is Mary Marigi audible? I can't hear her. Mary, if you can test your mic, please.
Yes, I can hear you.
Oh yeah, I can hear you now. Thank you so much. You're most welcome. I'm now going to introduce you. So Mary Marigi is a midwife and she is a sexual reproductive health specialist, and she has been working in Kenyatta National Hospital for the last 12 years as a midwife. And now I give you 10 minutes, please, to present your work. Thank you very much.
Good afternoon, listeners. I'm going to present about gold standard of care in midwifery because we realize that when we talk about obstetrics and gynecology, when we talk about obstetric and gynecology recovery, we cannot exempt midwifery care in this whole journey. So, Mr. Moda, next slide. We define gold standard of care as in health recovery as care that is holistic, comprehensive, that has high standard of care and practices that are evidence-based. And also this care should be woman-centered and it should have diversity in terms of culture. We should be sensitive when it comes to giving this gold standard care. There are components of gold standard of care, and one of them is woman-centered care. And when we talk about woman-centered care, we talk about informed choices and autonomy, because we want these women to make good choices of their health care, but they cannot make these choices if we don't give them the relevant information. Again, we should give them autonomy to make decisions without being biased, without any influence, so that they can make the best out of their care. And also, it should be individualized and holistic, because you can have 10 women, 20 in the ward, but all of them, they have their own needs, they have their own goals, they have their social and psychological issues. So we should not treat women antenatally or in labor or in postnatal as one, that there are all these women in labor. We should treat them individually. And continuity of care is something that is quite important when you talk about gold standard of care, such that if this care that a woman gets in KNH, can she go and get it in Machakos? Can she get this care in Mombasa County? And if she doesn't get midwife A on duty tomorrow, can midwife B give the same care the next day? And then we have to talk about evidence-based practices when you talk about gold standard of care. And when we talk about evidence-based practices, we are research-oriented, that this is care that is proven through research that is going to help our women. We are following the laid down guidelines and protocols, and is a care that is not outdated. It is modern, and also it is safe for the patients that we, or for the mothers that we are serving. Next slide, please. When you talk about midwifery golden care standards, we cannot do away with low intervention births, because we realize sometimes we do a lot of medicalization of even of natural processes. For example, labor and delivery is a natural process. It is normally a normal physiological process, but sometimes we can be tempted to intervene when it is not necessary. For example, unnecessary artificial rupture of membranes, augmentation, probably even induction before the due time. And we see all these things, they have their own repercussions. So if we can also be able, as midwives, be able to minimize interventions during the birth, it can be even better for our women and also for us as healthcare workers. And also unnecessary cesarean section. Lately, there are high rates of cesarean section in most of our facilities, and some of these cesarean sections are not even not necessary. Some of them come because we intervene too early without an indication. Then we have to talk about postpartum care. And when we talk about postpartum care, we look at this woman, as we said, holistically. We have to look at physical, monitor the uterus, and also emotional support. Remember, after delivery, most women, they can even get something like a burnout, blues. They need our support as midwives, as nurses who work closely to them. And of course, we cannot forget about mental health, because it has been an issue lately, postpartum depression, and we do a lot of physical care, we forget the mental health issues of these women. We have to do monitoring and response to complications, as we are with this mother antenatally, postnatally. We must be able to monitor them so that we can be able to detect complications. Complications like preeclampsia, gestational diabetes. And when we detect this complication, we manage them actively and early enough so that these women, we don't want to have mortalities, and we don't want also to have morbidities. So it is a holistic and a better approach if all of us can join hands and do adequate monitoring early enough to arrest some of these complications that we see. They give us sleepless days, sleepless nights, hectic days, just trying to arrest them when things are out of hands. Next. Mr. Mota? Then midwifery gold standard of care has a lot of collaboration. And when we talk about collaboration, we use multidisciplinary approach. As midwives, we don't work in isolation. We work with gynecologists, we work with neonatologists, nutritionists, every physicians, and we need to bring them on board when it is necessary and are enough. If we cannot handle some of these issues, we need to bring the multidisciplinary team for the better outcomes of the care that we are giving to these women. And then the next thing is that we need to refer these women or mothers are enough. Sometimes of the times, most mortalities and morbidities happen, and because of late referrals or something, we missed diagnosis early enough and a woman complicated. If we can do timely referrals when things are early, they can be arrested early, better enough for these women. And then we have to talk about cultural sensitivity, because we are working in a diverse environment. Different cultures, they have different beliefs about labor and delivery, but in general, childbirth. And community the way they perceive maybe labor and delivery is different from community B. And we have to treat these women according to their culture and what they believe, and also try to accommodate with the medical care that we are giving this patient. Finally, we also need to educate our patients, our clients, and empower them. Remember, knowledge is power. If we give these women good health education in all aspects, from preconception, during labor, postnatally, care of the baby, most of these complications, we can be able to avert them. And somebody talks about health education, which is a key for our women. In conclusion, next slide, gold standard of midwifery care is providing personalized care that is evidence-based, holistic, with low birth interventions. Thank you.
Thank you very much, Mary. I think that was clear. Ladies and gentlemen, I can see you are still asking questions, and I'm noting your questions. One of the big concerns is the CBD points, and we shall be able to respond to that. Before that, we have our last speaker, and I'm happy to introduce Eunice. Eunice Mundia, are you there? Kindly test your mic.
Good afternoon, everybody.
Afternoon, we can hear you. Allow me to introduce you, and then you take the floor. So Eunice Mundia is a registered nurse with experience in clinical nursing, maternal, neonatal, and child health, HIV/AIDS, health promotion, and research. She holds a Bachelor of Arts in Psychology from the University of Nairobi. And now, Eunice, it is your turn. Kindly take the next 10 minutes, and then we shall move to the plenary session before we conclude. Thank you for your patience. Thank you for your questions. Thank you for your engagement. Eunice.
All right. Thank you very much, Dr. Christine, for the opportunity. Once again, my name is Eunice Mundia, and I'll be taking you through elimination of mother-to-child transmission of HIV, which was formerly known as PMTCT, and currently we are talking about EMTCT, which is actually elimination. And our focus as a country is triple elimination of HIV, syphilis, and hepatitis B. Next slide, Mr. Mwenda. So why EMTCT in obstetrics and gynecology? One is because mother-to-child transmission is the most common way that children become infected with HIV. So most of the pediatric HIV infections are as a result of mother-to-child transmission. And then we realized that 20 to 45% of infants born out of mothers who are HIV infected, if no interventions are offered, they will actually get HIV. And evidence or scientific evidence has shown that the use of the currently available interventions can actually reduce the risk of mother-to-child transmission. Globally, there are countries that have actually been able to reduce this up to 2%. And in Kenya, we are not yet there, but our future and our target is actually to be able to reduce mother-to-child transmission rates to 5%. And when we get to 5%, we can actually talk of elimination, having achieved elimination of mother-to-child. So why integrate the EMTCT in maternal neonatal child health as stroke reproductive health services? One is because PMTCT services are most effective when integrated into reproductive health and MNCH services. This is because one of the major entry points for PMTCT services is actually during antenatal care. And then, of course, when we integrate, we strengthen linkages between maternal, newborn, and child health services. So we are able to offer these services within maternal and neonatal child health services, reproductive health services such as family planning, HIV and STI-related services to reduce the overall maternal and child mortality rates. So the other thing why it is important to integrate is because it becomes easier for mother-infant pair follow-up. That means that a mother doesn't have to come for family planning and bring a child for follow-up later. They can actually tie the two clinics together and have a mother pair infant being followed up and all the services being integrated under one roof. And then, of course, with integration, we have good retention and good adherence. Good retention in terms of we are able to follow up this the mother-baby pair all the way until they cease breastfeeding. We are able to monitor adherence for the PMTCT, EMTCT interventions, as well as ART adherence for the mother. Next slide. So EMTCT uses a four-prong approach. All the strategies that will effectively help us to achieve elimination of mother-to-child. And Kenya's triple elimination agenda is aligned to the global 4 prongs. So whatever we are doing here in Kenya is actually what is happening globally. And in prong 1, we look at preventing new HIV infections among women of childbearing age. This is where we offer HIV testing services, and once we offer HIV testing services for the mothers who are HIV negative and at a higher risk of contracting HIV, we offer them preventive methods such as PrEP to ensure that we do not have new HIV infections. Then prong number 2 is to prevent unintended pregnancies among HIV positive women of childbearing age. So they need to plan for their pregnancies so that we make sure that at the time they conceive, at the time they get pregnant, we have reduced mother-to-child risks. And then we move to prong number 3, which is now actually the prevention of mother-to-child transmissions of HIV infections from the infected mother to the infant. So this takes care of the pregnant women who are known positive or known to be living with HIV. Once they conceive and get pregnant, what are the interventions that we offer them during pregnancy, labor and delivery, and through the breastfeeding period to support them reduce mother-to-child transmission. And then, of course, now prong 4 is where we holistically look at this mother and provide care and support, not only to this mother who is living with HIV, but of course, we extend the same care to their children and their families. Next. So just to take you through the HIV testing national guidelines for mothers for elimination of mother-to-child transmission of HIV is that once we get a mother at ANC, is that they should be offered HIV testing services through what we call provider-initiated initiative, where the healthcare worker is the one who prompts the client to take a HIV test. This should be done at first ANC, preferably within the first trimester or at first contact. So at whatever trimester the mother presents, then we offer the HIV testing, testing services. And remember, they are consented. It's not mandatory for mothers to take a HIV test. So they consent for it so that they can have the test done. And then we will take retests for the ones who tested HIV negative at first and second trimester. We take a retest at third trimester. And then again, we'll take a retest at labor and delivery. And then after labor and delivery, we'll take another retest 6 weeks post-delivery at the point they present for Penta 1. And then thereafter, every 6 months until complete cessation of breastfeeding. So what we are saying is that we do not only offer HIV testing services at antenatal care, but it is a cascaded approach throughout to cover the pregnancy period, labor and delivery, and also during the breastfeeding period. It is also important to note, as healthcare providers, we should be able to establish the HIV status of pregnant and breastfeeding women at any service delivery point. So not necessarily in the reproductive health. So what is it that happens in ANC when we talk about integration? Other than the HIV testing services, the recommended visits are 8 antenatal visits, because this will help detect maternal conditions that could actually increase the risk of mother-to-child transmission of HIV. We offer partner testing and family involvement for these mothers to get the support that they need. And also by realizing that there are people who actually live in discordancy without the knowledge. So it is very important that we bring the partners on board so that this mother gets the support, and we also get to establish their HIV status as well. Then recognizing and responding to danger signs during pregnancy. Then we prepare the mothers for birth preparedness, including or with focus with skilled birth attendants. We don't want our mothers to deliver at home. So we give that information at ANC. And then counseling on individualized birth plan. How will they get to hospital? How prepared are they? Do they have a birth partner? And how do they know how they'll get to the hospital? Can they tell what are the signs of labor? So that is what is actually included in that. And then we also look at maternal and infant nutrition, because poor maternal nutrition is actually one of the risks to transmission of HIV from mother to child. Infant nutrition, because they need to make decisions on the mode of infant feeding. And then we also have to look at future family planning options. What is it that the information that they have on the available methods of family planning? Then there is also the proper management of HIV clinical appointments, which are tied together with the antenatal care appointments, provision of infant prophylaxis at first contact. And then we also strengthen community PMTCT strategies that will help support the mothers outside the facilities, TB screening for the known positives, and those who actually screen negative for TB, the provision of TB preventive therapy for them, then GBV screening services, and with GBV screening services for those who are identified to be going through any form of GBV, either physical, emotional, or sexual, we also link them up to for psychological support, and also for community services where they can get more support on that. And then of course, mental health assessment, screening for depression using the PHQ-9, PHQ-2, and of course, generalized anxiety disorders and making appropriate referrals. Next. Next slide. So in prong number 2, we talked about prevention of unintended pregnancies. And basically this is what is covered in that prong number 2, whereby we do not want mothers to conceive when they are at a higher risk of actually transmitting HIV virus to their infants. So one of the things that we should consider when preparing these mothers for conception is their nutrition. How is their nutrition? Because we know malnutrition is one of the things that will actually contribute to poor pregnancy outcomes, even in the non-infected population. Things like stillbirths, low birth weights, anemia, congenital malformations. So all these things we want to make sure that this mother is actually well taken care of. The number 2, we also want to ensure that they have STI screening, and those who are actually found to have sexually transmitted infections are managed appropriately. contraceptions to prevent unintended pregnancies for those who are not intending to conceive, lifestyle behavior and change, because we do not want mothers to conceive when they have risks to other, maybe like metabolic diseases, and the use of ART or HART to actually enhance undetectable viral loads, because we know when a viral load is undetectable, it is equals to untransmissible. So we want mothers to conceive when they have low detectable levels of the HIV virus. Next slide. So again, pregnancy intention screening for HIV positive women planning to screen, and then discuss their options to actually optimize their outcomes, depending on their clinical presentation, depending on the lab, and of course, factoring in people like who are in discordant relationships, who want to conceive and keep the other partner negative. And then, of course, there's the provision of comprehensive post-rape care services for those who may show up after a rape care, and then knowledge on HIV status so that they can also make informed choices. And of course, male involvement, which is very key to the success of every PMTCT intervention. Next. Next, okay. So just a wrap up of what we've just talked about in the previous slides is that we should encourage all HIV-infected women without pregnancy intentions to use dual methods. That is actually the use of condoms and any other hormonal or hormonal contraception, implants or injectable, because they are very effective even in making sure that they do not reinfect themselves other than protecting them from pregnancy. Take into account drug interactions between hormonal contraceptives and ART, because we know some ART drugs will actually reduce the effectiveness of family planning. So we do not restrict the use of condoms, emergency contraceptives, or surgical methods and fertility awareness methods for HIV-infected women. They are allowed to make a free choice. Lactation amenorrhea method is effective for women who are less than 6 months postpartum, who are exclusively breastfeeding and have not resumed their menses. Next. So it's also important for us to note that HIV-infected women should not be forced to use any contraceptive method if they do not wish to do so. And then it is also important for us healthcare providers to actively assess women's pregnancy intentions and continue doing that throughout the course of HIV care, so that we guide them through on how to go about it safely. And then it is also important for us to understand that HIV-infected women who desire pregnancy should be virally suppressed prior to conception, and that takes care of reduced mother-to-child transmission rates. Next. So once we get these women who are living with HIV, what are the interventions that we take? Of course, the first intervention after counseling is to start these mothers on ART, same day ART, and continue for life. So after that, we obtain a viral load 3 months after initiation, and then every 6 months until complete cessation of breastfeeding. Then it is also important for us to make sure that even if this person had a previous viral load and they present to us pregnant, we take a viral load at that point where we confirm a pregnancy and disregard all the other previous viral loads done before pregnancy. For pregnant or breastfeeding women who have a detectable viral load, that is any level value that is above 50, but the focus usually on 200 copies. And for the general population, the focus is on 200 copies. But for pregnant and breastfeeding women, it is actually up to 50 copies, because we are talking about low detectable levels to support reduce or to support elimination. So we need to discuss the patient in multidisciplinary team so that we can be able to know the best management for them, assign them case managers, and address the barriers to adherence that are likely to cause non-adherence. And then these women are followed up with 3 months enhanced adherence support through counseling. And then after the 3 months of excellent adherence, we have a repeat viral load and then continue to monitor them effectively. So that's basically what we will do for the HIV, for the women living in HIV, with HIV, who are actually found to be not virally suppressed during the breastfeeding and the pregnancy period. Next. So once the baby is born, how do we take care of this baby? Other than what all other babies go through, what is it that we need to do for the HIV exposed infants? One, of course, is growth monitoring, because we talked about undernutrition, malnutrition in our previous slides as one of the key risks to mother-to-child transmission of HIV. So we need to make sure that they are within the right, growth monitoring curves. Then immunization as per the KEPI program. But in the immunization, it is also important to note that these children will receive measles at 6 months. So they have 1 extra measles vaccine at 6 months, and then they continue at 9 months and 18 months, just like the rest of the population. Then we need to cancel on infant feeding options. And of course, the preferred mode of infant feeding is exclusive breastfeeding for the first 6 months, then complementary feeding at 6 months, and the mother can continue breastfeeding all the way until 2 years, or actually beyond 2 years if she so desires. And then we have to have infant ARV prophylaxis. This is the use of zidovudine syrup and nevirapine syrup. And zidovudine syrup, we use it until 6 weeks. And then nevirapine syrup continues all the way until 6 weeks after complete cessation of breastfeeding. So they will continue with nevirapine syrup until 6 weeks after complete cessation of breastfeeding. And of course, we introduce Septrin as a prophylaxis measure at 6 weeks. And then follow-up EID, early infant diagnosis testing, where we use DNA PCR at 6 weeks, at 6 months, and at 12 months. But from 18 months, we will take an antibody test, and we will take an antibody test every 6 months until the complete cessation of breastfeeding. Once they stop breastfeeding, we give an allowance of 6 weeks, and we carry out the final antibody test, which should actually be documented as HIV negative and discharge the infants from the clinic a follow-up. Next. One of the things that we should note as healthcare providers is that once a baby is infected or becomes infected with HIV as a result of mother-to-child transmission, is that we do not attach blame to the mother. We do not blame the mother for the transmission. Next.
Eunice, you need to summarize, please.
Yes, thank you. Yeah, and my last quote is just a quote on the why it is important for us to ensure that mothers and babies have good outcomes, that we comprehensively take care of these mothers, so that we give a chance to these mothers to take care of their babies when they are healthy until the time they see them grow up. So yes. So thank you. Acknowledgements to the Ministry of Health, Kenyatta National Hospital, and the National Syndemic Disease Control Unit, previously known as NASCO. Thank you.
Thank you very much, Eunice. Tessa Shitandi, Mary Marigi, Linet Ooko, Eunice Mundia, thank you so much for today's presentations. And as we take the plenary session, I'll lead the questions that have come forth, and then we can respond. The first question is, and the first big concern is on CPD. The codes are not reaching our participants, and therefore I request Mr. Mwenda to take this up. Participants are saying they've not had any CPD codes since December, and therefore we need to take this up and run with it. Question, did you find out how many women got information on cervical cancer screening during the postnatal period. That goes to Shitandi. And then Oko, please speak out the safest family planning method for a female. Oko again, you excluded women that were less than 4 weeks, which is considered, which the participants are considering to be a crucial period. Maybe you can comment on that. And then the age bracket for the target sample was also not included. Eunice, why do we have a global difference so that global is targeting at less than 2% and we are aiming at 5%? And do you also take a consent during the 3rd trimester for HIV testing, even though the client might have given a consent during the 1st trimester? Last but not least for you, Eunice, is does the letter U, apply in PMTCT vertical transmission? We'll take those ones first. Please summarize as you respond, and then we'll take 5 others that are pending. We will give 1 minute for anyone who wants to do an oral question. In that case, you can put up your hand. Thank you. Tessa, take it first, please.
Oh, okay. So there's a question on did I find out how many women got information on cervical cancer screening during the postnatal period? The answer is no. I only focused on targeted postnatal care. When you look at the national guidelines on quality obstetric care, it specifies like pre-discharge what content supposed to be given to women at 6 weeks, what should the women be knowing. So for me, I just focused on targeted postnatal care. Cancer cervical screening information is usually given at 4 to 6 weeks, and that was not my eligibility criteria. Thank you.
Could we have Oko next, please?
Okay, on to my first question. It was about the safest method of family planning. All I can say is safe is relative. What I want from my family, my family planning needs, like as women, they are different. There are those who need spacing, there are those who need limiting, and also there are those who just require family planning method. So we cannot say as healthcare workers, the safest method of family planning. The second question was about the age bracket. We decided to go from 19 years because of issues of consent and also issues to do with like people less than 18, ideally in the Kenyan setup, they're not supposed to be sexually active, or they're not supposed to have given birth. So most of the time, the women who are below 19 years tend to avoid to participate in studies. Their parents do not give consent for them to participate. Then, was there any other question?
Exclusion of women that were less than 4 weeks.
Postpartum family planning, as we can see from the latest guideline from the Ministry of Health, they said it's initially it was from 6 weeks, then they moved it to 4 weeks by the time I was doing my study. So unless the guidelines has changed from birth.
Thank you very much, Oko. Could we have Eunice? I think Mariga doesn't have a question. Eunice, please.
Yeah, there was a question on why in Kenya we are targeting at 5% when the rest of the world is at 2%. It's because in Kenya, we are in a resource limited setting. And this actually goes a long way in affecting our outcomes. But it is also important for us to note that what is globally acceptable for elimination of mother-to-child transmission of HIV is actually less than 5%. So even with the less than 5% targets, we are still on course in elimination. And then there was a question on consent. If a mother needs to give consent at the 3rd trimester and she gave the consent at 1st trimester, it is actually needed. For every HIV test, you actually consent the client afresh. Then there was a question on U equals to U, whether it is actually feasible in PMTCT or in vertical transmission. U equals to U does not apply in vertical transmission, but it will apply between the mother and her partner or partners. But when it comes to EMTCT, we do not actually give the U equals to U messaging for mother-infant transmissions. Thank you.
Thank you, Eunice. We have other questions. Kindly listen carefully. The first question is, what is the way forward for EMTC since most of these services have been dependent on donor funding? Question number 2 is that globally, we have aligned to Global Alliance commitment to end AIDS in children by 2030. Can we describe where we are as a country? Our president or CS Health signed a declaration in 2027. Question number 3, can we force a HIV positive woman who is pregnant to take ARVs? Question number 4, how do you approach HIV post moms who need contraceptives, yet they refuse despite counseling? Do we castigate them considering your key message? Last but not least, have you had any patient who has antibody negative at 24 months, later becoming HIV positive? And what is the rate of seroconversion despite being on MTCT? And there's a request for the slides to be shared. Sorry, I had not seen this last one. These last two. What are the current interventions in HIV medications with the cessation of funding? How is it likely to affect the mothers who are affected by HIV? What is likely to be the way forward? How expensive are the ARVs and affordability? And then the other one is, what is the current national EMTCT rate? Most of them, they seem to be yours, Eunice. Try to respond and summarize.
All right, thank you. So what's the way forward for EMTCT since most of these services have been dependent on donor funding? I think that the way forward is actually full integration into the services that we offer. So that should be able to bridge in the gap and ensure that there is continuity of services. Then there was a question on globally where we are committed as a country to eradicate new pediatric HIV infections by 2030. I would say we are on course so far, and actually we have moved on as a country. And together with the question that was asking about the current transmission rate, we are at about 8%, not very far from what our target is. So if we fill in the gaps, I believe, and I'm hopeful, and I believe we shall get there. Then there was a question on about forcing a woman who is a woman who is living with HIV and she's pregnant to take ARVs. If we can force, no. We cannot force a person to take ART. It has to be voluntary. But what we can do is to actually continue engaging them further, just to find out what their barriers are and help them address those barriers so that we can have optimal care for the mother and the infant. Then there was a question on antibody seroconversions after PMTCT. if there have been any cases. Yes, there has been cases, but most of these cases are actually attributed to re-breastfeeding. And especially when we had early cessation of breastfeeding and these mothers were not able to fit into the society, and they could actually re-breastfeed children after going through PMTCT, let alone infecting these children. I may not have the current statistics, the accurate statistics, but we will look into that. I think I've answered the questions. Is there any that I have left? The current situation is that we still have medications. We have not run out of ARVs, and so patients are still receiving care as they should. Thank you.
Thank you so much, everyone that has been speaking to us today, doing the presentations. Thank you for also responding to the questions. I'll give the last question. Is testing being done in labor? Any recommendations? And as I also try to respond to the question of donor funding, it's the elephant in the room, and we will have to give it a multidisciplinary approach. Certainly, we will have to look for ways of funding, alternatives, of course, engaging with the clients, engaging with their significant others, engaging with the government and other stakeholders, and I believe we will sail through. Is testing being done in labor? Any recommendations? The last question, please.
I'm assuming the question is asking about the KNH labor. Yes, it is being done in labor, and even if it was in a different setting, it's actually supposed to be happening.
Thank you very much. The concern about CPDs, our administrator, Mr. Mwenda, will be able to address that. He's very competent in addressing such issues, and he's going to take it up. Thank you so much once more, our 4 presenters, and everyone that has actively participated and engaged in today's presentations. Ninashukuru sana. Thank you so much. Next week, we are looking forward to talking about critical care. Critical care, we know we have it. We know we are doing so much. We know we have a few gaps we need to address, and therefore be ready to join in next week. Tag somebody also to join in, and let us continue to actively participate. Asanteni sana. Have a good afternoon. If we are meeting for the first time this year, have a wonderful year, 2025. Asanteni sana. Thank you.